Hey guys, how's it going? Welcome to my first video on my YouTube channel. I wanted to start up a video series talking about educational topics and things that I see in residency. My first video I'm going to do here is an approach to abdominal pain. It's a very, very common thing that we see in internal medicine, and having kind of a framework and some common differentials in your mind are really important. I'm not sure how long the video is going to be. I'm just going to go ahead and get started. The intended audience for my video would be, any healthcare worker, but primarily a medical student, an experienced medical student, or incoming intern or resident. So without further ado, let's go ahead and get started. All right, so the differential diagnosis of abdominal pain. First up, we have epigastric causes. We have dyspepsia. In dyspepsia, patients will have epigastric pain, burning, early satiety, and postprandial fullness. Just of note, functional dyspepsia is the most common cause of chronic dyspepsia. You'll have younger patients who may present with a variety of abdominal and extra-abdominal chief complaints, and may also have a history of anxiety and depression. Then there's GERD. These patients will have heartburn symptoms, complain of retrosternal burning, maybe a metallic acid taste, and their pain gets worse with meals or recumbency, which is when they lie down. Peptic ulcer disease, epigastric pain and dyspepsia. They may use the words gnawing, dull, aching, or hunger-like that is associated with foods. Also, if they have any long-term NSAID use, and I've actually seen peptic ulcer disease from patients using a lot of Excedrin. So if they have long-term NSAID use or any H. pylori, or if they have any signs of upper GI bleed like melena or anemia, this type of pain can also awaken a patient from sleep. Zollinger-Ellison I put under here, kind of under that, in which people have multiple ulcers, in which H. pylori may be negative, and on your history, there is no excessive history of NSAID use, and these guys will have a fasting gastrin level greater than 150. Can't forget about ascites. These guys will have a history of cirrhosis and have very distended and tympanic abdomens. And then also keep in mind SBP. These happens in patients who have ascites and will present with fevers and encephalopathy. Gastroenteritis, I think we've all had this at one point where maybe we eat the wrong thing, Montezuma's revenge. These patients will have generalized abdominal pain associated with primarily nausea, vomiting, and diarrhea is the big symptom. May have a low-grade fever as well. Gastroparesis, you may see this sometime in an outpatient clinic, in which a patient who has uncontrolled diabetes associated with nausea, vomiting, and postprandial abdominal pain, early satiety, and weight loss. All right, so moving to small bowel disease, we have appendicitis. This happens more commonly in 10 to 30-year-olds, in which they'll have sudden onset, first-time periumbilical pain that migrates to the right lower quadrant within 12 hours, and it's worsened by movement, walking, and coughing. They'll have associated anorexia, nausea, and vomiting, tenderness at McBurney's point, positive psoas and obturator sign, possibly some guarding, low-grade fever, leukocytosis. Of note, I found it interesting that the abdominal pain usually precedes the vomiting. If it's the other way around, consider this diagnosis less likely. Celiac disease, we have patients will have long-standing symptoms of abdominal pain after they consume gluten. They'll have some diarrhea, abdominal distension, flatulence, and some iron deficiency anemia. Since in celiac disease, the duodenum is the portion that's affected, and that is the area that absorbs iron. And they may have osteoporosis as well. SIBO, or small intestinal bacterial overgrowth. These patients will have distension, diarrhea, flatulence, and weight loss. And consider this in patients who have previous GI surgeries like gastrojejunostomies, resections, Roux-en-Y's, blind loops, or any other small bowel motility disorders like scleroderma, vagotomies, or diabetic enteropathies. And in severe cases, they may have multiple nutrient deficiencies. Lactase deficiency, or people who are lactose intolerant, they'll have diarrhea, bloating, and flatulence and abdominal pain after they have milk-containing products, and they get improvement when they're on a lactose-free diet. And ileus, patients will have abdominal pain after they have some sort of surgery or any electrolyte abnormalities, or any offending medications as well. They'll have nausea, vomiting, obstipation, distension, decreased bowel sounds, but they'll often have minimal tenderness. In SBO or small bowel obstruction, they'll have abdominal pain that is intermittent with borborygmi. That is kind of the high-pitched abdominal sounds. They'll have some cramping with associated vomiting, constipation or inability to pass any flatus or any stool. And they may also have a history of prior abdominal surgeries and from having adhesions. And then perforations, these guys, you'll know they'll be very, very sick when you see them. They'll have peritoneal signs such as ridging, guarding, and rigidity, and they also may be septic. Pancreatic disease, we have acute pancreatitis, in which they may have the abrupt onset of deep epigastric pain, often radiates to the back. Usually they've had previous episodes before and related to either binge alcohol intake. They may have nausea, vomiting, and sweating, worse with walking or lying supine, with associated fever, abdominal distension, and leukocytosis. Chronic pancreatitis also will present similarly. They'll have persistent or recurrent epigastric pain with some steatorrhea and signs of malabsorption, and they'll have a history of alcoholism. For large bowel disease, first off, we'll start with constipation. I believe that's pretty self-explanatory. Patients will say they just have not had a bowel movement for a certain period of time. Whatever normal bowel movements that patient has, it'll be longer and less frequent than what they're used to. And sometimes you can also feel stool on your abdominal exam. IBS, this is when their pain is not explained by any structural or biochemical abnormalities. They're going to have chronic, intermittent, crampy abdominal pain for more than 6 months associated with altered bowel habits. The abdominal pain may be relieved after defecation. There may be an associated change in their stool frequency, a change in stool appearance, and typically this pain does not occur at night or interfere with sleep. We have IBD, that is inflammation, whether that's ulcerative colitis or Crohn's. Patients will present with fevers, weight loss, and diarrhea, usually bloody in the case of UC and non-bloody in Crohn's, and symptoms will be intermittent. Keep an eye for extraintestinal manifestations, uveitis, arthritis, polyarteritis nodosa, and then diverticulitis as well. Consider this patients who have left lower quadrant abdominal pain, fever, leukocytosis, and nausea and vomiting. Hepatobiliary causes, there's hepatitis caused by the hepatitis viruses, A, B, C, and D. There are certain medications, autoimmune, and alcohol. These patients will have constant right upper quadrant pain. They may have a prodrome of anorexia, nausea, vomiting, fever with dark urine. They may have a tender and enlarged liver. And in their history, keep an eye out for excessive Tylenol use and your herbal supplements, recent travel, contaminated foods, shellfish, IV drug use, piercings, or multiple sexual partners. Cholelithiasis or gallstones, typically it happens more commonly in females, in which they get recurrent and episodic right upper quadrant pain after consuming food with radiation to the right scapula. And cholecystitis, which is inflammation. Once a stone is stuck in the cystic duct, patients will have more steady and severe right upper quadrant and epigastric pain after a meal with nausea, vomiting, fevers, leukocytosis. Keep an eye out for positive Murphy sign. We have choledocholithiasis and cholangitis that group together. They'll have a history of biliary pain, accompanied with jaundice, dark urine, and fever, and rigors, particularly for cholangitis. Keep in mind the triad and pentad of Charcot's triad and Reynolds pentad. Vascular causes, we have mesenteric ischemia. Keep an eye out for any risk factors of systemic embolization, such as a history of AFib, valvular heart disease, hypercoagulable state, and they'll present with typically abrupt onset of pain, and this pain is out of proportion to their exam. They may have an unexplained lactic acidosis or metabolic acidosis. A ruptured AAA is something we should all keep in mind in patients who are male, smokers, and who present with hypotension or syncope or orthostatic hypotension with a pulsatile abdominal mass and possibly decrease lower extremity pulses. Ischemic colitis typically presents with left-sided abdominal pain with bloody or maroon stool and diarrhea that involves the watershed areas of the colon, usually from non-occlusive diseases that cause a decrease in colonic perfusion. Budd-Chiari or hepatic vein obstruction, these patients will have right upper quadrant pain tender to palpation with associated ascites or jaundice. They may be hypercoagulable at baseline, and for this, you want to consider getting a right upper quadrant ultrasound with Doppler to reveal any occlusion in the flow of the hepatic vein. For kidney and bladder, consider renal colic or nephrolithiasis, rapid onset back or flank pain with associated hematuria, dysuria, and usually they're struggling to try to get comfortable. They'll be kind of writhing around while they're in bed. And also consider UTI. Patient will have dysuria, urinary frequency, urinary urgency. Cardiac causes, always consider an atypical presentation of acute coronary syndrome. Reproductive causes in females, consider an ectopic pregnancy or an acute ovarian event. And in males, consider testicular torsion. And some metabolic causes, consider hypercalcemia. I'm sure we all remember the mnemonic. Stones like kidney stones, bones for bone pain, groans from abdominal pain and psychiatric overtones, and DKA. Consider this in patients who have abdominal pain, who present with very high sugars, in the 600s, 700s, anion-gap metabolic acidosis, and a history of diabetes. All right, guys, I know that was a lot, but I just wanted to go through just a little framework of my approach to abdominal pain. I hope you guys learned something. Take care, and I'll see you in the next video.